2024. It's Indian Standard Time, 9:30 a.m. We are joining in for a special session today for CMAAO 168 International Weekly Meeting. We are talking about cancer today. So we have Dr. C. Sairam. He's joining in from Hyderabad. He's a director and senior consultant oncologist at Swarna Sai Hospital with over 22 years of experience in medical oncology, preventive oncology, and radiation oncology. And we are here to discuss cancer incidence and NASH. Sir, I would like to introduce you and for the session to take forward.
Can I start sharing slides?
Yes, sir.
Thank you for nice introduction. We would be having explosion of cancers in the world. The cancer incidence, as you know, is surpassing in some countries. Earlier, it was cardiovascular disease in most of the countries in the world, but in some countries, it is surpassing cardiovascular disease also. So this is a apt time to discuss internationally how to know the cancer incidence and how to adjust our budgets and priorities in cancer management. Since we have varied spectrum of people, I'll try to be as basic as possible because it has to be understood by non-oncologists and non-physicians also, because as per the invitation, we have a lot of dignitaries of various countries participating. So I'll try to be as brief as possible from technical point of view, but if there is anything, we can discuss over the question and answer session. So what is cancer? Everybody knows, I believe. It is a tumor. Tumor means it is collection of cells which have lost its type of behavior from the main category. Let's say, for example, salivary glands. Salivary gland function is to have saliva secretion, but it will lose its main priority of producing saliva, but it will start multiplying more, and it will try its infiltrating various places in the body. That is the tumor which develops, and that type of behavior is labeled as cancer from layman's point of view. In this, we'll try to discuss about type of cancers, magnitude of problem, etiology, preventive, and slightly on other aspects also, because just otherwise it will be a statistical presentation. So a little bit of other things also I'll try to cover in my presentation. This is the synopsis, and regarding the other topic which is given to me, that is mostly from radiologist and pathologist point of view, but still that also I'll touch in brief. So the cancer is, as I've told, abnormal, uncontrolled cell growth. WHO definition is the rapid creation of abnormal cells which grows beyond the usual boundaries and which can invade adjoining parts of the body and spread to other organs as a process referred to as a metastasis. Metastases are the major causes of death from cancer. For example, breast cancer. By breast cancer patients die not from the primary, but from the metastasis. So we need to know about metastasis, how cancer spreads by metastasis. Metastasis is spread of cancer from one part of the body to another through blood vessels, lymphatics, or direct spread. Adjacent organs, it invades, and secondary tumors or metastasis can develop again its own metastasis. Carcinogen, any substance that causes cancer is carcinogen. So these are all things which enable cancer cells or group of cancer cells to become malignant. So next, so tumor develops in few cells, then it will hyperplasia, means that it will multiply, and then uh, during the process of multiplication, there is lot of abnormal cells, abnormal mitotic cells developing, and if they are confined to that particular part, it is called in situ cancer. And when it starts invading blood vessels and lymphatic systems or other tissues deeper inside, it is invasive cancer. So our purpose is to catch the tumor in situ stage or very early invasive stage and treat it. That is our aim. So this mainly starts with normal DNA. When normal DNA becomes abnormal in by acquiring all these properties, for normal DNA to uh, have these properties, the nucleus becomes bigger. Means the cell property means the cell property itself will make its priority to multiply and divide. The cancer cells divide most rapidly than any other normal cell in the body. That's why we attempt to see the cancer treatments, attempt to see how we can prevent this multiplication. It's like so. Mutations are the abnormal behavior. I mean, abnormal changes in the DNA, which which are irreversible, and these can be caused by radiation or chemical carcinogens, pollutants, or any other viruses or any other things which can change this DNA pattern. Next. So genetically altered cells are mostly because of genetic preponderance. Like example, we have about 10 to 15 tumors which have hereditary profile tumors like retinoblastoma, breast cancer, pituitary, pancreatic cancer, endometrial cancer, prostatic cancer, pancreatic cancer. Like that, we have certain genetic predisposing cancers. So these are the genetic mutations which alter the cells. Next, the spread and second mutations, they are the main properties which makes the cells more aggressive. If the tumor has the ability to spread and divide faster, they are more aggressive. Next. So for that, they have various properties of producing new blood vessels. This is called neoangiogenesis. And then that tumor cells can grow and they can start mutating. Next. So further, blood cells will permit these tumor cells not only to enter the tumor and cause vascularization of the tumor, it will also help in spread of the tumor. Next. This has the property of breaking through membranes, that is direct spread also. Next. So this angiogenic property, we have certain drugs also to prevent this angiogenic properties, and radiation and also helps in preventing this new angiogenesis. Next. So this invasion also is prevented by our radiation, or we remove that cells wide in surgery. We remove surrounding normal tissues because we may miss this micro invasive cells. So that's why we do. So that's why we do this particular wide excision during surgery, or we give more margins while giving radiation to prevent this problem. Next. Tumor cells can travel to blood lymphatics, direct spread, and through various cavities, transcoelomic. spread. That is, lung cancer can spread through adenovirus through transcelomic spread. Like that, ovaries can also harbor through transcelomic spread of gastric cancer and other cancers. So these are the various ways in which the tumor cells can spread. Next. So there are various types of tumors. Tumor is a collection of cells. There could be benign tumor, like for example, mole is a benign tumor. Malignant melanoma is a malignant tumor. So this tumor is only collection of cells. Next. There are various differences between benign and malignant tumors. Benign tumors resemble more like a normal tissue, whereas malignant cells, tumors have various changes which I have enumerated, like nuclear and cell cytoplasm variation, and so many other things which I have already enumerated. Next. Next. So coming to the cancer epidemiology, we have latest one is Globocon 2022. We have almost instance wise, if you see, it's almost the numbers are, these are the only which are notified through various cancer registries or through various population based cancer registries. In actually the incidence, if you check it will be much more than whatever is been predicted or projected, because cancers are still not a notifiable disease in most parts of the world, at least not in India. So unless until we have cancer as a notifiable disease, exact statistics or exact incidence would be very difficult to be uh, be predicted. Next. So if you see, all over the world, lung cancer is one of the commonest cancers. But in some parts of the country, let's say for example, in India, if you see, we have adenic cancers. Adenic cancers are, but most of the cancers, if you see, lung, colorectal, liver, breast, stomach, pancreas, but this keeps varying from country to country. Next. So, if you see, this incidence and mortality is still very high in certain parts of the country. For example, cancer survival rate is hardly 50 to 60% in developing countries or India and South Asian countries. But in developed countries, because of the cancer screening and other advances, the cancer survival rates are almost up to 80%. Next. So uh, we have 30% of cancer deaths due to 5 leading risk factors, that is high body mass index, low fruit and vegetables, lack of physical activities. Tobacco accounts to almost 40% of cancers. Alcohol accounts for 4% of cancer deaths. And pollution accounts to almost 25% of the cancer deaths. And we have HPV, HCV, all those things account for almost 20% of cancer deaths in low and mid income groups, where HPV is still not the universal immunization program. It's been implemented in India recently, whereas in other countries, in certain other countries, it is already been there for quite some time. For say, for example, in UK, the cervical cancer is the 10th commonest cancer. Next. So these are the various global cancer of India. Like we have almost 14 lakh 13 new cases. Number of deaths are almost 9 lakh 16,000. So you see, number of preventable cancers are almost 32 lakhs. I mean, so most of the cancers can be preventable So we should try to concentrate on prevention aspects more, at least in a resource constraint center as a priority. Next, statistics at a glance, if you see, the cancer deaths are about almost in males 4,70,000 and in females it is 4,46,000. In both sexes put together, it is almost 9,16,000 in 22. So age this age standardized mortality is almost 66%, male and 62% in females, and combined is 64%. The risk of dying from cancer uh, before the age of 75 years, because most of the countries have cancer starting at 75 or so, but risk of dying from cancer before age of 75 is almost 7.5% in males and 7% females. It is both sexes put together 7.2. So top three leading cancer risks, deaths, if you see, lip, oral cavity, lung, esophagus, and in females, if you see, breast, cervix, uterus, ovary, breast in both sexes, if you see, breast, lip, oral cavity, cervix, uterus. These are the data we have here. Next. So top five most frequent cancers are males. If you see, this is the thing like lip and oral cavity, because we have lot of tobacco as a chewing habit, as a brush. For brushing they use, as something they use, uh, apart from smoking. Reverse smoking also is power is also part and parcel of certain pockets in tribal Andhra area and other places, because the females don't want to be shown in predicted to be identified as a smoker. So these are the, and if you see in females, earlier cervix was supposed to be the top cancer, but now breast cancers are taken over because of various efforts by gynecologists in preventing cervical cancers by individually vaccinating or early screening and interventions. Next. Next. So genetic, lifestyle, environment, and viruses, these are the main causes of cancer. Next. Genetic mutations we have seen before. So these are oncogenes and tumor suppressor genes. This plays a very important role in genetic mutations. Next. Chromosomal changes in the genome, cancer cells make them. These are all the terminal deletions, insertions, invasions, isochromosomes, like that. These are all the things which happen in the chromosomal level. Next. So these are all the oncogenes, oncogenes and tumor suppressor genes which control excessive cell growth. Next, these are also helpful in our immunotherapies and all. We have these properties are used in immunotherapy research by manipulating the regulatory cell division. Next. So lifestyle, of course, this alcohol is a big industry. Alcohol per se, they have almost 4% as a soul, but most of the time tobacco and alcohol together are used, so they account for major causes of cancer risk. Next. So we use a lot of coloring agents, dyes, preservatives. So these are all the and chemicals in work environment like asbestos, and other things, radon in watch batteries, and radiation exposure, ultraviolet radiation, sun baths and all. microorganisms. Like we have lot of like HPV related cancers and hepatitis C related malignancies, Epstein-Barr related vaccines, and H. pylori related malignancies. These are all the microorganisms which cause malignancy. Even they say that COVID virus has lot of changes in cancer in cells, and there would be very high preponderance of cancers in the future. Like after hepatitis, we get cellular carcinoma. After Epstein-Barr virus infection, we get lymphomas. After this H. pylori infection, we get gastric cancer. Like that. After COVID, the predictions are that there would be huge rise in cancer incidence. And we have ionizing radiations because there are ozone holes have been uh, been happening rapidly, and they cause X-ray and UV radiation mixed. These are the various viruses which have been known to cause, and in that, at least from uh, experimental virologist, COVID is also, they think it is a oncogenic virus, and the finer details would be knowing in future. But in cell lines, they have shown that even COVID virus is an oncogenic virus. Next. So, age is a prepondering risk factor. Let's say, for example, a tumor in a child has 1 in 7 chances of being detected as malignancy finally, but in elderly population, 1 in 3 tumor could be malignancy. So age is a major risk factor. For example, prostate cancer incidence, if you see, it is highest in the elderly population, so also breast malignancy and overexpression of estrogen. That's why uh, they are trying to label the fat, uh, like cheese, has to be labeled as a carcinogen. That's what a lot of propaganda is going on, because the hormones used in poultry uh, are getting into this milk, and those cheese made from this poultry is having a lot of estrogens, and they are supposed to be carcinogens. And family histories are already I've told, it's almost 10 to 15% in various sectors of the population. If they have close related marriages, like singles and all, they have higher hereditary cancer syndrome. If they have distant marriages, that hereditary uh, cancers are little less in this group of population. So, to prevent, avoid tobacco, control diet and weight, dietary fiber has to be increased, exercise has to be done. Protect skin from sunburns, use sunscreen, avoid environmental occupational carcinogens, be aware of warning signs and symptoms, and recommend screening, like how it is practiced in most parts of the developed countries. Next. So, thickening or lump, these are the warning symptoms. These warning symptoms itself would help us in diagnosing advanced cancer. That's why screening has to be done before they develop warning symptoms. But still, we have to propagate at least these warning symptoms as a method to popularize investigations if they have any of these things. So, again, for change in bowel bladder habit, indigestion, difficulty to swallow, unexplained changes in weight, unusual bleeding or distress. These are all the things. Next. So, uh, this prevention and early detection is the best way of cancer. So, 30, about 30 cancers are due to our habits and activities. At least in the mm, but if you see in our parts of the country, almost this number would be much bigger because we have a lot of tobacco and alcohol habits. Next, about 70 to 80% cancer cases are detected in late stage, at least in developed countries where there is no proper screening as a part of I mean, uh, government regulated screening. It is only done on an individual basis, so it has to be part and parcel of the system. Like how we have universal vaccination, like that we should have universal training also to be taken up in a big way. So tobacco has to be banned, but unfortunately, even in New Zealand, those restrictions which have been uh, introduced have been relaxed of late. So tobacco industries has to be tackled by the various dignitaries who are attending should to take it seriously and see that tobacco is banned. Next. Apart from tobacco, there are all other betel nuts and other things. Next. Alcohol is also 4% alcohol. In the NASH, which we'll be discussing, how the alcohol is the positive agent in liver cancer. We'll discuss in that our NASH presentation at the end of this one. Fat and other things which already I have told. Next. So this type of charring, like say for example, in certain fishery population, they just burn the fish and take it as almost stable food. So those charred food also taken by this fisherman seems to be a carcinogen. Next. So pollution 25% I already told, and in this certain factory workers also this is one of the major cause for mesotheliomas and other malignancies. Water pollution uh, in in certain populations, like where industrial waste like lead, mercury, and all is getting polluted and entering the water, and it is causing cancers in certain belts where the this pollution is there. This belts where this pollution, water pollution is there, those areas who are consuming this, they seem to have a lot of gallbladder cancers and other cancers which are related to water pollution. Next, X-rays should be limited as much as possible in preventing cancers. For example, PET-CT, we've done more than 5 times. They have the secondary cancer incidence almost doubling and tripling. Like that also, we have to restrict X-rays during pregnancy. Next. So viruses, already we have discussed about all these viruses. Next. Heredity, we have discussed so many. So now the priority is to has to concentrate on screening on hereditary based cancers, uh, then extend to other non-hereditary cancers. Next. Because hereditary cancer screening is supposed to be very cost effective. Early detection is the most useful thing. Next. So cost wise also it is very economical to do early detection and treatment. Next. So already danger signs we have already seen. Uh, so next. So laryngeal cancer is one of the curable cancers uh, which can be detected with just changing voice and other things. Next. Oral cancers, people who are going for dental checkup regularly, they seems to have good survival when compared to those people who are not having dental checkup regularly. So oral cancer screening, dental checkup is to be advised as frequently as possible. Next, lung, of course, you know, any chronic cough more than 2 to 3 weeks must have been investigated. Apart from that, change of voice, chest pain, shortness of breath, asbestos, cold or etc. Next, breast cancer also we should start at least in high risk patients. We should start screening uh, blacks where the hereditary profile like BRCA1 and BRCA2 seems to be higher. They have to start screening as soon as they complete the childbearing age, at least after 35 years of age. They should be start investigating. Next, cervical cancer screening has to be done apart from this vaccination. Next, so colorectal cancers, this month is a colorectal cancer awareness month, stool for blood test, and changing bowel habits, constipation, and there are various other tests also. Colonoscopy, all those things has to be done whenever, as per the colorectal screening guidelines, at least by 45 onwards. Next, so they now predict 40 years and above is better if the family history is there. Next, physical screening is not a part of most of the countries, but in some countries where uh, in Japan and other places, they have a screening bogies, balloon, cytology techniques that has to be done in the belts where disease free cancers are high. Next, screening is done when the woman or man has no symptoms. Next, those screening tests should be cost effective and it should be not very much harmful to your things. But in high risk things, we can go ahead to an extent in like hereditary profile patients, BRCA1, BRCA2 positive patients. We can go to an extent of even doing MRI and other investigations also. So low dose CT scan for chronic smokers. Also, apart from regular 10 years, 45 what's this, 10 years of high tobacco consumption screening, that is the least screening done in most parts of the country. It's so dictum is to do biopsies because cytologies are no more confirmatory and it only is costing more and wasting time. So we to try to do biopsies as far as possible because now we are doing lot of targeted therapies. So that is how we do go ahead nowadays, and uh, we try to prevent our let's say if we do FNEC, the chances of detecting is almost 60 to 70% only in most of the tumors, but in a biopsy it is it's almost 96% onwards. Next, so these are all the various changes the cancer cells will have. This is for pathologist point of view. Next, so there are various stages like stage 0 or stage 1 where we intend to detect any cancer screening. Next, if we detect at stage 4 or stage 5, stage 4 or stage 3, survivals would be very less. Next, these are the TNM staging systems where how we have depending on the extent of the tumor, nodal spread, and metastasis. Next, the grading is the pathological grading, which the pathologist will give based upon the biopsy. Next, stage, grade. These are all the things which I have taken into cognizance for starting and giving treatment. Next. So, treatment point of view, surgery, radiotherapy, chemotherapy, hormone therapy, biological, immunotherapy. These are all the things which we are practicing. Apart from that, we have a lot of ablative therapies also, and a lot of interventional treatments also coming up. Next one. So surgery is removing wide excision, what we do for a tumor, unlike a benign tumors, where we don't do wide excision. So in surgery also there are a lot of advances like uh, robotic surgery, minimal access surgery. Uh, next, so radiation also we have lot of particulate radiation, conformal radiation, and high dose perfractation, and various other techniques are also there. Next. So goals of radiation is when the surgery is not feasible or if patient is not fit for surgery or for organ preservation or make the tumor operable, we use radiation. Next. These are all the various, we have brachytherapy also, where we keep radio active sources adjacent to the tumor or close to the tumor. Next. So chemotherapy is the where we use cytotoxic drugs for tumors, for cancer patients to divide rapidly multiplying cancer cells, but it also affects rapidly dividing cells in the body like blood cells, epidermal cells. So they will have the side effects of anemia, mucositis, hair loss, etc., vomiting, loose motions. So we now go for targeted therapies, biologicals. Next. Yeah. This is the summary of the cancer treatment. Now we'll go to our next topic. Next.
Thank you, Dr. Sairam, for your slides and your presentation. I'm sorry, but I think there was an echo in the voice, but I think we have managed to complete the presentation. A
little bit more if we have time.
If you have time, we can go for the.
Sure. But can you just see if we can fix the voice since we have closed the presentation?
Yeah.
There's an echo in the voice.
Is that okay to hear us?
I think you're using the two systems. So can we mute one system?
Yeah. We close one of it.
Can you try now? You need to unmute one. Both the systems are muted.
Now is it better?
Yeah, much better. Let's go.
So in this presentation, we'll see how alcohol and these viruses play a role. Next slide. So these are all actually it is mainly from pathologist and radiologist point of view how this classification is done and how this various fat accumulation in the liver goes on to cirrhosis and the cancer formation is depicted. So if it is more of technical thing which may not be very useful for our dignitaries. So I think we'll go ahead with the question and answer session.
Do we have more slides?
Yes, slides are full.
Slides are work. Okay. So thank you so much, sir, for the wonderful presentation. I also have Dr. Chong, our chair from CMAAO, joining us from Singapore. Dr. Chong, would you like to take it forward? I believe cancer is something which is a topic for discussion for every country, and a lot of deaths are happening recently, and a lot of cases are getting discovered for cancer. And I think a lot of questions would be there. So over to you.
Thank you, Dr. Sairam. Sorry, I joined a bit late because I was caught up with my patients. But I just have a question. We see a lot of fatty liver in our practice, and you might have answered this question earlier. But is there any way I can predict a person's going to get NASH or just good old fatty liver?
I mean, I was part of this Emerald trial. This, as far as my knowledge goes, there's no way to detect earlier. Only thing is that we should prevent alcohol consumption. Even chemotherapy causes a lot of fatty liver and fibrosis. And we should try to prevent viral infections or hepatotoxic drugs. These are we have only preventive methods, and we don't have exact predisposing, means like hereditary predisposing factors or anything that we don't have, to best of my knowledge.
Yeah. So it's still very difficult to figure out who is going to become NASH, right? And who is going to stay as fatty liver. Because that's one of the biggest headaches I have actually in my practice. I got so many fatty livers, I can't figure out who's going to become NASH and who's going to stay fatty.
It's very difficult.
Yeah, thank you. Thank you for clarifying that. Any Dr. Hussain, Akhtar?
Hi, good morning, Chong. Good morning, Dr. Sairam. Thank you very much for excellent presentation, a lot of information. Dr. Sairam, I just saw one patient last week presented right thumb abscess. And when I was doing that abscess, a lot of blood came out, and it was not just ordinary abscess. I thought, then I sent whole specimen to the lab, and then follow-up result came epidermal sarcoma, and I never thought it is going to come up as a sarcoma. So it was a small lump, abscess, basically abscess. So do you see this situation in the epidermal sarcoma common in your practice? And the second point, second one, how do you break bad news or cancer news to the patient, and how they accept, and how do you break this news? Thank you, Dr. Sairam.
We have diabetic foot. Most of the time, there are guidelines how to do biopsies, how to do culture sensitivity. When you using your best of the treatment, and if you don't find the abscess is not coming down, you have to take not only cultures, you have to do biopsies also. Because unless until you take a tissue and examine under microscope, you would not be able to differentiate between infective lesion and malignant lesion. For example, tuberculosis, tuberculosis is also cannot be differentiated from malignancies unless until you take malignant biopsies. So whenever you, in spite of giving appropriate antibiotics for a certain period of time, if it is not coming down, biopsy is mandated. And regarding the second question.
Second question was, how do you break your bad news or cancer news to the family, and how is they accepting, and how do you handle those?
Yeah, HIV testing, HIV counseling, how we do, we have to take the help of psychologists, palliative care specialists, and we have to slowly take them into confidence, and we have to reveal the thing.
So we have one question on the Facebook. It says, can we have the liver completely recover from NASH?
Yeah, we don't know, sir. That previous question also we have told no. We don't know how and which patient will progress. But we have to take appropriate treatment depending upon viral load and other things, because we don't want the insult on the liver to continue. Like if patient is on any chemotherapy or toxic drugs like paracetamol and other things, chemo. So avoid those uh, insults on liver, or if the patient is having viral infection, or if the patient is alcoholic, we have to see all the insults on the liver to be stopped immediately. That's only in our end, but no other way of manipulating the progression.
Actually, Dr. Sairam, this whole topic of NASH and fatty liver is a huge problem because it's
Yeah.
all linked to visceral fat as well.
Yeah.
And visceral fat is actually the mother of all the evils, right? It generates all these cytokines and all these things that increase heart attack, stroke, cancer, and everything. So this is actually a huge problem in whether is it in the developed world or in the underdeveloped world. It's a huge problem globally. I think it's the mother of all the chronic diseases.
Yeah.
One more question. In terms of the diet, while there's a NASH patient and its recovery, do you think the liver detoxification really helps to improve the process?
Yeah, avoiding fat is a part of dietary management, but that alone is not sufficient. Most of the time.
Do we have any more questions on the floor? Dr. Monica, would you like to make some comments?
Thank you, Dr. Sairam. This was a great presentation, and it's also very relevant to everybody who is watching the presentation. Just like we saw that an abscess can come out to be something that is not an abscess, I think keeping ourselves vigilant and being aware of the potential diagnosis of malignancy is important. Especially in the realm of having many more therapies, many more options, against a backdrop with the involvement of behavioral health and palliative care is also very important. I think it's an important concept to underscore that patients should always be given the free right to understand the risks, the benefits, and the alternatives of therapy for any malignancy, including the option to not pursue therapy. So we should always be very aware that what we consider necessarily as what is the way we would like a patient to move forward in the treatment course may not be what the patient chooses. Also with NASH, because of its association with metabolic syndrome and multiple conditions associated with obesity, diet, lifestyle, diabetes, etc., it'll be interesting to see how the role of the medical approach to weight management, which is becoming a huge portion of healthcare right now, and how that will lead to outcomes in the NASH presentation. But there's, I think, yet a lot to be determined. So we are in new territory, I think, in a lot of healthcare where obesity is considered to be a large factor. Your slides were beautiful, very clear, a pleasure to see your presentation. So thank you for your time. I just wanted to give you some feedback about that as well. It's always nice to have information that's organized and presented as well as it was. So thank you very much for your time.
Thank you.
So Dr. Chong, I believe we can close the session, and I don't think we have any more questions on the floor.
Thank you, Dr. Sairam, and it was a pleasure listening to you. I'm sorry I was a bit delayed, but I caught whatever there was, and it was pretty impressive. Thank you very much, and much appreciated. This is a topic that we usually, it's a little bit off our radar, but nevertheless so important as for the reasons I've already outlined. Thank you again, and look forward to everybody next week or a week after for our next session.
Thank you.
Thank you so much. Take care.